Hello, thanks for reviewing this narrated PowerPoint presentation on trauma triage at CHI St. Elizabeth Hospital. This is Dr. Rick Vermilia, Trauma Medical Director. The phrase on our national website for CHI states that we want the right care in the right place, and this accurately describes why we want to triage accurately. And I would add that we want the right people with the right skills to be available when needed and when it's appropriate. Trauma triage systems and trauma triage criteria are used throughout the United States and across the world. Trauma systems need to triage accurately for several reasons. Number one, we need to transport the patient to the appropriate trauma center with the appropriate capabilities. Number two, we need to activate the appropriate trauma team and more specifically, figure out when we need the trauma surgeon and ultimately an appropriate admission service to admit the patient to the hospital with traumatic injury. This is our triage system. It's based on our resources and capabilities at CHI St. Elizabeth. We try to triage away or quickly transfer trauma patients once they're stabilized that are better cared for in a higher level trauma center. We call our first level trauma team response a full trauma team alert. Lincoln Fire and Rescue, LFR, uses the World Health Organization's field triage criteria and call them a level 1 or category 1 response. We call our second level trauma team response a partial trauma team alert. Lincoln Fire and Rescue uses the World Health Organization field criteria and call them level 2 or category 2 responses. We use the term partial trauma team response because that's the term used in the Orange Book, the criteria that the American College of Surgeons and therefore the state of Nebraska verified trauma centers. Please do not consider a partial trauma team response as a weak or compromised, half-hearted, or half-serious response. The word partial is not a partial effort. We still need to respond as an organized trauma team with a team resuscitation leader and a lead trauma nurse in timely fashion with genuine leadership. The standard that we have set for a partial trauma team response is that the patient will be seen by a provider within 5 minutes of arrival. The trauma team leader needs to respond specifically the emergency department physician or an ATLS certified emergency department APRN or PA. The ATLS primary survey and the secondary survey need to be performed. This is not a cursory look from the door. It's a hands-on process that is vocalized to the team and documented in EPIC. This primary and secondary trauma assessment, as seen in ATLS and TNCC, needs to be vocalized for good communication, documented well in the provider's note, and documented in the trauma nursing record. It's recommended that the provider develop an EPIC template in their SMART phrases that includes documentation of the primary and secondary survey and of the trauma team criteria that the patient met. The partial trauma team includes a trauma team leader, the trauma RN, an ED tech, a respiratory therapist, and an X-ray tech. The purpose of this is to rapidly assess a patient that has a concerning mechanism of injury. Now, full trauma team alert criteria, if you notice, have either an abnormal physiology, like an abnormal GCS, low or no blood pressure, or respiratory distress. Note that it's not a high respiratory rate, it's respiratory distress. Or full trauma team alert criteria have an anatomical observable finding, such as a penetrating injury or more than one serious pelvic or long bone fracture. This is physiology or anatomy, not mechanism. Please do not activate a full trauma team if they, quote, were in just a scary sounding accident, end quote. We had to leave some discretion in these criteria because all injuries do not conform to these exact criteria. However, we want you to be looking for these criteria Keep in mind that by activating a trauma team, you are spending a lot of resources. We charge trauma team activation fees of several $1,000s, even in partial responses, to insurance companies now that we are verified as a trauma center to cover the costs of these resources. Please understand that by activating a full trauma team response, you're asking the trauma surgeon to literally drop whatever they're doing and respond in person. Trauma surgeons may be in their office across town, in the operating room, or at an important family function, or at home sleeping when asked to respond. Trauma surgeons must find a way to leave our present patient safely and respond. Trauma surgeons are asked to take consecutive days and weeks of 24 hours a day call, and they don't work shifts. So we can have some very long periods of time when we're taking trauma call. Full trauma team responses should only be called by an ED physician, an ATLS trained advanced practice provider, or by a registered nurse. We need to know who called it and why they called it, and this all needs to be documented. By activating a full trauma team response, you are stating very clearly that we need a trauma surgeon at the bedside now. The reason for this is that the American College of Surgeons Committee on Trauma recognizes trauma to be a surgical disease that needs surgical management and intervention. When documenting a trauma response, whether it's full or partial, make sure you literally name the exact criteria on our triage card that was used to activate the team. This should be vocalized and understood by the team during evaluation, and this needs to be documented in the provider note and in the trauma nursing record. It's never appropriate to document the word mechanism, but to name the specific criteria listed here in gold. If you document high index of suspicion for a partial or full trauma team response, this should be rare. But document what about this case concerned the person who called the response. When the patient meets anatomic and physiologic criteria to warrant a full trauma team response, the first thing to do is to put the patient in room 19, the trauma resuscitation room, or room 20 in the pediatric trauma resuscitation room, including those pediatric responses called in the pediatric emergency department. When you call a full trauma team response, recognize that you're using a lot of personnel resources like the chaplain, security, radiology techs, phlebotomists, the CT scanner and techs, the blood bank, the pharmacist, and you're drawing them away from their ability to care for other patients. When you have a full trauma team activation because the patient meets anatomic and physiologic criteria, the trauma team leader needs to act as the trauma resuscitation leader in the room until the trauma surgeon arrives. If St. Elizabeth's gets advance warning from the field, hopefully the trauma surgeon will be present on the patient's arrival. But trauma surgeons do have a 30-minute response requirement. A trauma team timeout should be communicated to the trauma surgeon to transfer the status of team leader from the emergency room provider to the trauma surgeon. During this, the room should get quiet for a presentation of the patient following ATLS protocol. In summary, know the criteria and refer to the card when activating a trauma team. Make sure that a full trauma team response has an anatomic or a physiologic criteria. Only ATLS certified providers or TNCC certified nurses should call a full trauma team response. Document the activation in Epic. Look at the triage card and record who called it and the exact criteria that they chose. This includes documentation by ED providers and by nurses. Please document a full ATLS or TNCC workup. Do not use only the word mechanism for a partial response. Find the partial trauma criteria that the patient met and please record it. Make sure a partial trauma team response has a complete, vigorous, and timely trauma team evaluation. Thank you so much for watching this narrated PowerPoint presentation. Thank you for your skills and your service to the CHI St. Elizabeth Trauma Program. We appreciate you.